So
right.
we need
She's
to
recording.
know what's normal, so we
All right.
can identify, give it a name, like we do in ACLS.
Thank you.
But your basic waveform, P, Q, R, S, T, and sometimes a U wave. Who remembers why we have a U wave? What could be causing a U wave? Potassium, up or down? Okay. Hypokalemia. And if you remember from A&P and from last semester, electrolytes are very important to cardiac function. Remember, cardiac cells work from that, I think the terminology, excitability that we use, the characteristic of cardiac cells. Excitability. They're excitable because of that constant traffic of sodium, potassium, calcium across those cellular membranes. That's why we drill in your heads, look at electrolyte levels. That's why we like those nice normal ranges. Too much or too little, and we don't get the right amount of excitement or the right amount of cardiac function. Okay. And on the back of your first page, you know, we have every rhythm that we look at, either normal one or abnormal when we get into ACLS. We have to give it a name. We have to give it a label. And when we're looking at a rhythm, when we're standing at the desk looking at the cardiac monitor, or we're standing beside the patient's bed in the unit, or when we're looking at a printout, looking at, say, the doctor or practitioner's ordered EKG, we're looking at a hard copy of that EKG. What are we literally looking at? When we look at a monitor, a printout of the EKG, what are we looking at? Picture or a graphic illustration of the electricity. That is it. There's the heart, two functions, two basic things. Electrical, makes the mechanical. That's the unique, one of the unique things about cardiac cells. They make their own activity and respond to it. If the electrical ain't good, mechanical ain't going to be good. So that's why we look at monitors. That's why we have to assess and label and find out what is wrong with our patients electrically, so we can fix that and get the desired mechanical response that we want. When we start looking at strips, first thing, there's like 4 or 5 things you want to do. First thing you want to ask, is it regular? Just eyeball it and ask, is it regular? You don't have to have it with fancy calipers. You can just, with your eyes, with the calipers God gave you, you can look at a strip and decide, is it regular or not? What do we mean by regular when we say, is it regular? What do we mean? If you were to have calipers or were to get a ruler or some kind of measuring device, if you were to measure from every P wave to the next one all the way through, or every QRS complex to the next one, it would be evenly spaced. For OCD people, it's quite easy to pick out. It's regular, it's good, I'm good. You also want to rate. That's really important, especially when we get into the abnormal things. And we want an atrial rate and a ventricular rate when we're looking at the rhythms and or dysrhythmias. What do we mean by atrial and ventricular? What are we looking at? What are we going to assess? When we look at it, when I tell you, look at the P waves in the patient's monitor strip, what are we assessing when we look at the P wave? Well, that's PR interval. PR interval is the time. Just the P wave itself, what does that mean? Atrial depolarization. Okay? QRS, or as one student told me, the little funky thing in front of the big pointy thing. But P wave is atrial depolarization. Anytime you see the word depolarization, that's the electrical stuff. Depolarization, repolarization, or dispolarization, those words all deal with the electrical component. So anytime we see a P wave, that means atrial depolarization. QRS complex tells us about ventricular depolarization. So in the Mr. Rogers world of cardiovascular activity, we have 1 P for the QRS. That's what we need to get a rate. We want an atrial, we want a ventricular. And normal is what as far as the rate? Normal between 60 and 100, that's correct, but there's 1 P for every QRS. A P, QRS, and a T, that's 1 heartbeat, that's 1 cardiac cycle, and that's what we want to maintain. We want to recognize. And P waves, are they regular? You want to look those before we give our rhythm or just give them a name. Just give them a name. And one thing we'll, especially when we talk about the blocks later on today, and with Mr. Rogers' role of cardiology, like we just said, there's one key for the QRS. When we start looking at some of the atrial dysrhythmias, ventricular dysrhythmias, and some of the atrial ones, there may be multiple key waves for the QRS, which you need to count. Some of the ventricular dysrhythmias, the ventricles are the terrorists taking over. That's what we get the picture of. The key waves kind of buried, we don't see it. When we would get into the Jesus bus, like you feel, you tap those things. Okay? So is there one key for the QRS? And try to stay away from memorizing things, but when we start looking at those heart blocks, the 4 heart blocks we're going to look at later today, there are classic things that go along with the PR interval, the characteristics and the relationships between P's and QRSs. And we're going to look at those in detail. And then PR interval, which somebody mentioned it earlier, that's the time frame. Everything is set in stone, the conduction system, the normal pathway, and everything has a specific time frame to get this job done. Top of the heart, starting the SA node, has a time frame for the impulse starting and sit on, and then the ventricles have a time frame, then there's nothing. Normal PR interval is 0.12 and 120 seconds. 0.12 and 120. And then it's only fair for the atrial compartments have a time frame. It's only fair that the ventricles have their time frame as well. As far as for the ventricles to depolarize, you're also going to the QRS complex, 0.04 up to 0.12 seconds. 0.04 up to 0.12 seconds. That's in Mr. Rogers' role of cardiology. Everything is normal. Our electrolyte levels are normal. The conduction system is working like it should. That's what we get. So to give a rhythm a name, first, is it regular? Side, is it regular? What's our rate? Is atrial rate equal to ventricular rate? Next, we will look at the P wave. Are they there? Can we actually pick them out? Is there a one-on-one relationship? Which is what we want to see. If there's not a one-to-one relationship, what do you see? What pattern? Are there too many of them? Are there some QRSs that are alone? What kind of pattern do you see when you look at the P waves? And again, those time frames, the QRS goals. What is it? And the QRS duration. What is it? Yes.
PRM, what is it?
It's basically, it's all the electrical activity above the ventricles. It's the time frame, 0.12 to 120 seconds. That's how long it should take for the SA node fire and send it on and it gets to the ventricles. It's basically the time for all the electricity above the ventricles. Any questions? Conduction pathway. Again, set in stone. SA node, primary pacemaker part. In normal situations, it's what runs the show. And that word primary tells us what? We say SA node is the primary pacemaker. What does that say? It's the big dog. That's who's running the show, and that's who it should be. Next is our AV node. What word do you see associated with the AV node as far as basic functions? Secondary. Word secondary tells us what? It can do it, but it ain't supposed to be as primary. Okay? And then we go to the bundle of PS, down the bundle branches, left and right bundle branches, and then we reach the Purkinje fibers. Which Purkinje fibers, if you remember, they're all over, and that's the ventricles. When it gets there, it travels out through those little finger-like projections, those fibers, and it's in the ventricles. What do you remember about the ventricles, besides the really larger pumping chamber in the heart? What do you remember about the ventricles? What can they do if they have to? They contain some pacemaker cells, and they can initiate impulses. Number one, they can do that, will do that, if there's a major failure or blockage or something wrong with the SA and the AV node. The ventricles get no instruction. They're kind of like a child think of you in comparison with shopping, the SA node, primary pacemakers, Macy's, the AV nodes, JCPenney's. The ventricles, they have to pace the heart, it's like Family Dollar and Dollar General. Not anything against those stores, but we're kind of going down in quality a little bit. So, now, when we get into dysrhythmias, something sometimes upsets that normal production system. Most of the pacemaker cells are right inside the SA node, but there can be some scattered outside of. But anytime, what happens when we throw a hot cell into cardiac cells? What happens when we fry something with oxygen? It ain't gonna work right. It's gonna get flared up. Sometimes with an eye or with valvular disease. In unhealthy hearts, sometimes our blood flow is not what it should be, so that can cause irritability. Those electrolytes we talked about when you're out of balance, that can cause a problem with the production system. So everything's got to be in good working order for everything to work like it's supposed to be. The ventricles, like I said, they can pace the heart if they have to. They're third in command, so we really don't want it to. But because there are pacemaker cells there, again, you take a patient with severe coronary artery disease, somebody who smokes, then smokes. You may have deprivation, you may start to develop the coronary artery disease, blockage in arteries. Not enough blood in your ventricle tissue, it's toxic, it's irritable, and because of that irritability, the ventricles can fire impulses on their own, in addition to the SA and AV ventricle. Any questions about it? Okay. I was talking to Loretta. I know you're used to having things to take notes, but we wanted to make you a bigger copy so you could look at the strips better. If you want to write things underneath and stuff, you can. But wanted you to see a bigger picture, a little bit clearer than the little tiny with the lines to write notes on. Okay? But you may not need to write any notes. This may all be, a lot of it's just going to be review. What is BLS? Basic life support. What is BLS? What are our three primary things of BLS? ABCs, airway, breathing, circulation. Well, what is ACLS? Advanced cardiac life support. What's our basic? Do we still have ABC as our three biggies? Yes. Airway, breathing, circulation. But we also, with advanced cardiac life support, we're going to be adding a D and a D. This is my own thing. But D stands for drugs. Primarily for the patient if you need a bag of Xanax before you go. But drugs and electrical therapy, that is advanced cardiac life support. And it's a wonderful thing. And when Loretta and then started doing this, how many years ago did we start ACLS? It has been the difference in getting people getting jobs. I don't know that it needs, some other schools I think are copying us, but that's not something that new graduates come out with. It makes you very comfortable. Because you cannot work unless you on a telemetry floor, critical care, or an emergency area, pretty much without having ACLS. And if you were to have to pay for it on your own prior to being employed somewhere to get it, talking about $175 to get it, maybe more than that. So this is a gift. It's not making it punishment. You are very fortunate to have this. So it's going to make a difference, like I said, for some of you getting a job. What do you fear most about ACLS? Jesus bus coming after you? What do you fear most?
The word mega code.
Mega code. My very first ACLS class, when I was a mere child, I was 20, I was a registered nurse age 20. My first ACLS class, I took it, I was thrown into it with people who've been nurses for years, with a doctor who was one of the biggest sports pursuits that had ever gone face in College County. And I told you that several times in the past. Anyway, here I am with all these nurses, scared to death. Back in those days, had that stressor. And in this class, Mr. Burnett and Dr. But he always picked out somebody we could pick on. In fact, our goal nowadays, still in the whole county and here, is for everyone to pass. Those days, it's easy enough to pass, it's fine with us. So, I'm scared to death. I've never seen a code. And I'm in this class, and he literally pulled me aside every one of the stations and gets in my face and says, "You need to go home. You're wasting my time and yours." So anyway, got through it, and it sounds worse than it is. But I can remember the mega code. That was probably what I dreaded the most. And I can remember the mega code. And we had 2 or 3 mega code stations, and people were kind of Dr. Nash to not get in the station because he was a bud. He was a horse's bud. He's like, "I don't believe I acted like that." I'm like, "Yeah, you did. I was 20 and stupid, but you acted like that." But I was getting ready to do my mega code. I was hiding. I was back in the bathroom, probably in the back, but I was getting down the bathroom. He's like, "Come on, you're going to do mega code." So I get in there and I'm doing this, and my patient, it was some type of bradycardic rhythm because I know atropine was her first drug. And I he says, "Your patient's not going home." I said, "But they don't matter, they didn't have to." But it's a lot better than it used to be. And you get all the instruction and things that you need. So what else besides mega code? What else? Drugs? For yourself? Both? Okay. Let's see if I can. Okay. This isn't the one from upstairs, is it? I hope. Okay. Drugs, you're afraid of what? So you're afraid about drugs, and PR interval, you were to measure those all the way across. And when your rhythm is regular, there's no need other than practice and to measure all the way across. When everything's regular rhythm, the right amount of waveform, and 1 P for QRS, you can just measure 1 PR interval and 1 QRS duration. It's when we get into irregularity that we want to do more than one until we get to the heart loss. That'll make sense. Some normal sinus rhythm. Regular. We have 1 P for QRS, meaning our atrial and ventricular rate is even. Regular. It will fall between 60 and 100 beats per minute. And all the time frames are normal. That is a normal sinus rhythm. Anytime you see the word sinus tacked onto a name like a rhythm, spread, or what is the word sinus? What sinus means? What you can undertake with your brain to the word sinus? All the players are there. Like sinus bradycardia, all the players are there. They just make it short, they're slow. Sinus tachycardia, all the pieces are there, but for some reason you're jacked up too fast. Sinus bradycardia. Sinus means all the pieces are there. Bradycardia, it's just too slow. The rhythm is regular. There's 1 P for the QRS. It's all the parameters of the definition for normal sinus rhythm except for the rate. It's too slow. Do we treat sinus bradycardia in everybody? Treatment symptomatic. Is the sinus bradycardia normal for anybody? Marathon runner? Not me when I'm at Trojan working out. When I was on the elliptical for an hour last night, I don't even tell you what my heart rate got up to. But I got a good workout. But most people, sinus bradycardia, like a marathon runner, I've seen resting athletes have a heart rate 50 up to 40s. Asymptomatic. Frequent symptomatic. For us Joe Blows who aren't, we're trying to do good, but we're not Ironman or women, we're not marathon runners, what would happen to us if our heart rate was 50 for an extended period of time or upper 40s? We're going to become what? Symptomatic. And you just told me the drug of choice for symptomatic bradycardia that comes to that is atropine. Atropine accelerates. Now, for the general population who aren't marathon runners, what are some things that cause the sinus bradycardia? There's just nurses in the regular setting, in ACLS class, when we're working on the unit or the ER. When you identify something, what should we be doing? What should we be doing? What's caused this? Trying to put the puzzle together. What's caused this? What could cause a sinus bradycardia? Medications. What medication? Probably 85% of the population under 65, what are they on right now? Well, beta blockers, calcium channel blockers, and from clinicals, think to what's probably the most frequently given medication you've given in your nursing career? Lanoxin, digoxin. So it could be medications. Medications are being, which till I worked at home health, I've never thought it was a big deal for somebody. My gosh, you take a pill once a day. How hard is it? It's very hard for some people. And as I've gotten had to get older and take a couple medicines and vitamins and stuff, if I had to take a whole lot, I'd have to have a big pill packet of minutes so it's prescribed. It is easy to forget. What else is important in some of these taking medications like Lanoxin, other than taking the same time every day? What else? Check labs, check levels, check your electrolytes, like I said. So it could be medications that you're on. They may have had a rapid heart rate for some reason, and they put on Lanoxin or digoxin, a calcium channel blocker, or beta blocker. Polypharmacy, that's true. We talked about that last week with our elderly assessment. A lot of people go to a lot of different doctors, take a lot of different things. They don't always tell you. Don't know if I shared with this group, but when I was working on health in the school, I went out to do a proton on somebody. An elder man, he was heart patient, he had chronic atrial fibrillation. He was on Xanax, and he also took Coumadin because somebody with chronic atrial fibrillation, they're prone to clots. So unbeknownst to me, 3 different children had taken to 3 different doctors, all of which were prescribed Coumadin. Guess what? Of all the pills he did take every day, he took all 3 doses of Coumadin. And we're like 40 miles. This is the day. This is before cell phones. I think I had maybe a bag phone or cell phone. I took this one in proton. He won't leave. I'm like, oh God. He didn't have a phone with him. This was some other patients did not. So I literally put the pressure dressing on, and literally he asked me to have to drag him at a wall phone, a phone on the wall in his kitchen. He said, well, go call. I said, you need to come with me. I don't want to. I said, you got to come with me. Called the ambulance, got it in, take a long story short, proton's about 70, just like a crazy God to get the guy out there, and we'll call it down the road. So medications prescribed to treat a condition we can get too much of. And I've seen patients come to the ER, a cold or near cold, and it was their electrical system messed up because they're not taking their medication. So medications can cause a sinus bradycardia. What else? Suction. Anytime you stimulate vagus nerve and suction to do that, that is why we limit how many seconds you go down when you do intrathecal suction. That can do it. What if your patient may not be a cardiac patient, but they come into the emergency room and they've got severe gastroenteritis, they can vomiting diarrhea? What might, if somebody just been vomiting, they might have bradycardic heart rate. What else? How about the head injury? Maybe they're, not every code or not every cardiac situation that comes into the emergency room is a 90-year-old or 70-year-old having a heart attack because of pure cardiac disease. It may be from electric shock. It may be some young people, street drugs or being on drugs. Yeah, the heart's been stuck electrically, but it isn't always from old age and things like that. There's some other things. So maybe a head injury, maybe they were in a car wreck, close head trauma, creating pressure can cause sinus bradycardia. Treat with atropine, treat with symptomatic, and for most of us, most patients that come to the emergency room with the sinus bradycardia are down to 40s and they're symptomatic. Okay? Sinus tachycardia. Let's go, just one take a step back. If atropine is a drug of choice, this is more ACLS stuff. If atropine, what if it doesn't work? What else can we do? Say their heart rate's 42, and we've maxed them out of atropine. With atropine, you give so much IV push for a total of 3 milligrams, and if it ain't working, it's probably not going to. So what would be, from an ACLS standpoint, what would have to be done until we could do something else? Pacing. With an ACLS, there's pacings can be temporary or can be permanent. And some patients, elderly, the conduction system just wears out. And whatever, the bradycardia does not respond to atropine, and we must pace the heart. Put on an expert pacer to electrically, to apply the electricity to get us 60 kilometers per minute so we can do some more puzzle putting together, finding out what's wrong. And in some patients, they have to have permanent pacing before the conduction system wears out. Okay, now sinus tachycardia. Sinus tells us all the pieces are there. And it fits all the definition of sinus rhythm with the exception of break, if it's too fast. And on Thursday, when we get a ACLS, we're going to talk about stable and unstable tachycardia, wide angle, narrow angle, medium, high rise, and low rise. We're going to get really freaky on Thursday. We're just kind of reviewing sinus tachycardia. were irregularly outside of the data code, taking vital signs, you will be tachycardic probably. But anytime we get stressed or upset, and think back to why does our heart rate increase? Which we stress, that's just increased ocean demands. Fever, what does fever do to our bodies? We have a fever, step growth. One of my good friends took her daughter into my this morning to see Mary, and they took the little girl birthday today. She's 7, and she made cupcakes to take to school, and she woke up sick, and my friend sent me a text and said, well, we've got the little girl calls it strap throat. She gets strap throat, usually once a year. She's got strap throat today. Her fever was 103 this morning, so probably even for a 7-year-old, she was tachycardic. So fever increases our metabolic rate, and it can increase our heart rate. What if we stay up all night studying for ACLS this week and have 3 pots of caffeinated coffee? That can cause a sinus tachycardia. What else? Dehydration. If you remember from endocrine, somebody who has a thyroid condition. So if I could choose one disease, okay, I'd like to be hypothyroid. If I got to choose a disease for a little while, not that I want illness, but I've always done illness. I had a friend who was diagnosed and did not want medication with her. She lost 40 pounds in like a month, and her house was spotless. So she's like, I think you're gonna die. Okay, I guess I'll do medicine. But it could be a metabolic condition, a serious one. What about somebody who's bleeding? Maybe they're coming to the ER and been in a car wreck, they've got internal hemorrhage bleeding. Remember that little scale we talked about, cardiac outputs on this side, and stroke volume and heart rate over here? The cardiac output drops. What's the only thing on this other side of the scale? What's the only thing that can happen to try to improve cardiac output? Increase the heart rate. Does that work for a long time for everybody? One of us, which I consider all to be physically healthy, the mental part, questionable. But we might tolerate, or we could tolerate a heart rate 140, 150 for a while and not have a lot of compromise. When you take a 78-year-old person or 80-year-old person who we know has coronary artery disease already, they may have had an MI in the past, they've got unhealthy vascular system, they get a real nasty infection, etc. We're not going to tolerate that increase in heart rate. So we've got to intervene. Again, underlying cause, find out what's causing it, and treat it symptomatic. Like for us, most of us, we had strep throat or infection. We might tell our heart to beat a little bit fast, but we would not be syncopal or having chest pain and that sort of thing. For somebody with true cardiac problems, they don't tolerate that very long. So if you think back, it all goes back to that cardiac cycle, like your ventricles are filling up, the diastolic phase, your heart rate's in the normal range of 60 to 100, those ventricles are getting like they need. The faster that heart rate gets, the ventricle's still going through that phase. If somebody's clicking along at 150, 160 beats per minute, the ventricle's not still very long, it's not moving much blood, and therefore it doesn't have much pump out. So you see your symptoms of tachycardia. And since we'll talk about on Thursday with tachycardia, are they stable versus unstable as far as how we treat? What would be, Eric said you're worried about drugs, what would be some drugs that somebody might be prescribed to slow down? Johnson, calcium channel blockers, beta blockers. I think we talked about it just a little bit, but sinus tachycardia, all the pieces are there. It's all the descriptions of all the sinus variations fast. Do you remember we talked about SVT, or SVT, remember that? SVT is supraventricular tachycardia. What does that mean? What does that word supra? Supra means above. So supraventricular tachycardia, or SVT. A lot of people get it mixed up because we talk about VTAC and ventricular tachycardia, but this is SVT is a in my lunch hour, and I just happened to I stayed there for lunch studying and taking a nap, and I just looked out in the lobby, and this guy who's kind of scroungy looking anyway, but I look at him and he's gray, and I'm like, and I said to one of the office girls there, I said, what's that guy? Oh, he was walking on the scene. I said, I don't know, sort of red or something. I'm like, no, it's gray. Well, we don't see patients till 1 o'clock. I said, well, it's 12:20. I don't know, we'll be at 1 o'clock. So I get him back, I go out and bring him back to the clinic area, and I couldn't even, I tried to, before I got my stethoscope on, I tried to just palpate the rate of pulse, and it was like, oh. And then I get my stethoscope, and it's very, very fast. We did have a cardiac monitor at that time. Had nasal O2 and epinephrine. Big help. We definitely didn't need epinephrine. So I said, I got to take him across the hospital. Well, why? I said, because. So at this time, Mary comes in from she's going to smoke, and she comes in, and we get him over there, like down the we just push him across the gravel. We get him in and get him into the emergency room and get him hooked up. And he's in SVT. His heart rate's like hanging right at 200. And get him, of course, there was no ER doctor there. It may not be different. Somebody's on call, but they're not in the emergency room. And the nurse works at the ER, she works the floor, she's kind of enlisted. So, make long story short, we got the cardiologist called the local physician. He's like, well, you're very very much. Okay. So, gave the guy, which Watterson, if you remember from your reading and studying, that's drug for a real rapid heart rate, a real fast diabetes. I called it the beer ball. You give it real fast, 6 milligrams real fast, and you get some asystole, you get totally real fast adenosine in your heart, which that was a great choice for this. The guy tells me he's taking nothing but some Tylenol. Gave him the medicine, and then you repeat that dose, and in a few minutes you repeat the dose at different rate or different straight, repeat the dose, and the goal is for it to pulse like a few seconds of asystole and normal production picks up. It never even, no asystole, it's the first time I've ever given it, and I didn't get that asystole. And kept talking back and forth to the cardiologist with a top screen. We were doing a kind of top screen, and then gave him, I think blood pressure finally got him down to about 170. That's the lowest really got him paid us. I think the highest we got was 135. He said, we didn't want to do it. So, but in the meantime, the guy had a tattoo of the Red Reaper on his right arm, and I thought, Jesus doesn't really come get you in the Red Reaper and taking you away. The ER nurse was there giving the medicine, and she opened the card and she's reading the package insert at the bedside of the patient, and his heart rate's going up. I'm like, here, I'll do that for you. Anyway, that afternoon, Dr. Walker called. The guy survived, but he was positive for everything on the top screen. And Dr. Walker said, lesson learned. When it's a cocaine-induced SVT, cocaine that goes off the receptor mechanism and on. I said, well, I've never seen it not work. He said, well, no, itself, if it's cocaine, it's not going to be problem. So anyway, the guy survived everything, but it's like don't lose, taking care of it. But SVT, supraventricular tachycardia. Some people, of course, it can be a drug-induced thing, but some people, a lot of these young athletes, some people have syndromes, and they have like re-entry type thing. They actually have a conduction disturbance. You know, you see these athletes coming over. One of my good friends from high school, her son, they never knew he had a heart problem. He was fine. He was passed out a month ago. Of course, it was potty, that's exciting and stuff. But come to find out, he had like a little extra pathway. They had to send him to an electrophysiologist and then like some extra pathways. And you have extra pathways in your heart, and the pulses can be fired and travel and enter, and that's why you see a lot of times in the okay. Yes.
She said that the rate is 62 to 100 to 200.
Or higher.
That's a ventricle rate, right? The atrial rate.
No, in SVT, that's the whole thing. Don't confuse that. No, atrial fib, you may have an atrial rate of 350 to 650. Yeah. But in SVT, supposed to watch their caffeine, they weren't supposed to take any medicine or drugs, and if they do that, they would do well. Sometimes, if they would, I had one patient who Mountain Dew was her vice, and she would just, most people go on a speed liner and they drink alcohol, she would do without regular Mountain Dew, and then be somewhere, and she would come in, so we need to drive the window, she would come in and get medicine diabetes, so we slow that down and get it on the way. Since we talked about bradycardia, that somebody who's been suctioned or when we stimulate the vagus nerve, it slows the heart down. Is there something you might try with a patient who's like an SVT to try to get a little quick fix to relieve this stress? Valsalva, like bearing down, like spraying the stool. What? Local straw. I've seen ER doctors with people who told them to put them in ice water. You can do a lot of massage. I've seen doctors do that. So one told me they're not to do it. And I said, you got 6 figure income to do it. This lady I know got clots and stuff. Just said, you want to rubber neck to do it. Even on one side, I said, you're the one that can do that to do it. Anything that stimulates the vagus nerve can sometimes give you a fix with this if the person's really not tolerating it. So 2 sinus dysphagia, sinus brain, sinus tap. The names kind of explain what's going on. Look for underlying causes, do it perfectly. Then there are a couple of still top part apart, atrial dysphagia, atrial flutter, atrial fib. And like we said last semester, healthy hearts don't flutter fib. Usually with atrial flutter and atrial fib, we have coronary artery disease, we have valvular heart disease, we have a heart that's not healthy. Maybe somebody that smoked for a long time might have atrial fib and atrial flutter. Remember, SA node is the primary pacemaker, and that's where most of the pacemakers nodes are. But there can be some others located in that vicinity as well. And with atrial flutter, it is an atrial dysphagia, but you have few areas, you may just have one area outside the atrial node, and it's kind of impulses on its own. From irritability, hypoxia, whatever's causing it, usually hypoxia, or just an electrical disturbance in a different pathway that's going there. When you look at this atrial flutter, what's our ventricular rhythm? Is it regular? Is it regular from 2 hours to the next? Is it irregular? Yeah. What about, is there just one P wave or 2 hours? No. Can you distinguish and pick out a definite P and a T between those 2 hours pulses? Okay. Because those are all abnormal P waves, flutter waves. Remember what we said they look like? Salted, picket pin, soft, shark's teeth kind of thing. Which with atrial flutter you have more than 1 P for the QRS. I like to think, I think I said last semester, with the guys usually pick on the rate, I hope you all continue that. I think I use the terminology, I like to think that the AP node is having female qualities, like intelligence, for example. The AV node, there's some extra firing places outside the SA node making impulses. Like here, there's like 3 abnormal flutter waves, which is QRS. And normally, we like it to be a 1-to-1. The impulse starts up here, the AV node receives it, and transmits it on. That's why I say the AV node has female characteristics. It knows how to do this. It's working as fast and hard. Not that females are lazy. I mean, the intelligence is not that they're lazy and don't that 1-to-1. But the AV node, like every 4 impulse, like, okay, we've got to get some electricity, we've got to get a pulse, we've got to get a good rate going here. So that's what happens in atrial flutter. The SA node, or outside the SA node, is an area of irritability making impulses, but the AV node is going to block every so often. And flutter is an flutter, it's a 2-to-1, 3-to-1, 4-to-1, meaning every third beat, the AV node lets go through the ventricles. Like I said before, every fourth beat, it'll stimulate except it's similar to the ventricles. So therefore, your ventricular rate is trying, the AV node is trying to maintain the ventricular rate that is fairly regular, fairly normal in the number. So look at the difference. That's atrial fib. Atrial fibrillation is probably the most common in the elderly population. Again, healthy hearts don't get a flutter. If you were, is the ventricular rhythm anywhere remotely regular in a fluid? Okay. But it is a flutter. Your ventricular cadence is regular. And there's just, in this particular illustration, there's just 3 key waves and other waves in front of every QRS. All those little squiggly lines, those are all key waves. And this is what we're thinking about. So in atrial fibrillation, if we were to try to count all the key waves, which is what those are, it could be anywhere from 350 to 650 key waves per minute. And the AV node definitely is like, ain't no way we're going to explode. So it lets, what you'll see a lot of times on EKG or maybe seen on a chart, it will say atrial fibrillation with a rapid ventricular response. Most of the time in atrial fibrillation, the person's pulse or heart rate is above 100 usually. Because the AV node is like terrorism taking over. Lots of irritability. But there's no way the AV node can match 1-to-1 and it would be a QRS for every one of those arrays. So it lets them go through, and the more irritability there is, the ventricular rate will get faster and faster. And then usually they have the rate, it might be upper 90s, but usually it's above 100. Now identifiable key waves, irregular ventricular rhythm, and a fast ventricular rate.
So essentially, the ventricle is just going beep, 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 and the atrial is just sitting
The
there.
atrial is like my butt when I jog. The atrial compartments are fibrillating because of all this abnormal electricity. The AV node is kind of just randomly letting those get through. And it will eventually, the heart rate will get faster and faster. It will never match it. But you've got basically like both parts of the heart are not, the top and the bottom are not working together in sync. But you have atrial fibrillation, you have the atrial compartments fibrillating.
And then every now and then, one of them.
The AV node is like, okay, go on through, I need the ventricles need some work, need to do some work. But if you remember back to that cardiac cycle, when the ventricles are in the diastolic phase and are filling up, the ventricles are still, the atrial chambers are working. And just by gravity, blood flow is going to go from top of the heart to the bottom. So we depend on atrial kick, which is rhythmic contractions of those atrial chambers to get all the blood down to the ventricles that we need. In fibrillation, you're just up there, there's no atrial kick. That's why patients in AFib are prone to clots, because blood stays still and stagnates and clots. So you've lost an atrial kick. So yeah, talk about both parts of the hearts, it's an S. Yeah. So both of these are atrial dysrhythmias. I said this, I think this was more organized. It's still a dysrhythmia, but there is more regularity to it than this. This is a hot mess. It's not, my teenage patient says, this is a hot mess. Healthy hearts don't live in the flutter. We're talking ischemic heart disease, coronary artery disease, upon admitting 6 months during atrial fib or around atrial fib, they will be on medications like digoxin, beta blockers, calcium channel blockers. They will also be on some kind of anticoagulant because hearts that fib clot. Atrial fib, you have blood that's stagnant, and you're very prone to clots, pulmonary embolism, those kind of things. Now, remember we talked ACLS is airway breathing circulation, lead drugs, contact drugs, electrical therapy. What are our two options of electrical therapy for looking at cardiovascular? Okay, the paddle machine, they call it a defibrillator. But the defibrillator with the paddles, we actually have two functions. We can cardio work and we can defibrillate. What word goes with cardio work? Cardioversion, remember, synchronized. Synchronized. It's so important for getting to the info, things like that. Cardioversion is synchronized electricity. And we cardiovert to calm down, slow down, fast. What's the word synchronized? Why does that go with cardioversion? What's the key there? What's the connection? Synchronized and cardioversion. The patient that requires cardioversion has a heart rate. It's a crappy one. It's a rapid one. It's a fast one. It's one that could get on the music bus if we don't stop it. But we cardiovert, calm down, slow down, but the most important point being they've got a heart rate, they've got a pulse. We don't like it, we've got to fix it, we've got to calm it down. So it's really important. Synchronized means we're going to have to give them electricity, but that electricity comes at a point where the cardiac cycle and those waveforms are acceptable to it. Okay? The other electrical function is defibrillation. What's the only thing that we defibrillate? You got AFib, you got a defib. Defibrillation is unsynchronized, higher amounts of electricity, fluid as soon as you ascertain, yes, this is the living of patients in AFib, that's defib. Cardioversion, patients who are unstable, like the SVT, the supraventricular tachycardia. Cardiovert patients like that, who number one are stable and don't, a lot of drugs don't help them, or they're unstable from the get-go. So if the cardiovert has heart rate like SVT, you might have to cardiovert somebody who is still fit if they don't respond to drugs and/or are so unstable from the get-go that you can't wait for drugs to work. So the cardiovert to convert the chain faster than the slower, more acceptable one. Synchronized. That electricity we don't like to get calm down. AFib, defibrillation, not synchronized. The only situation that we, I should say there's two situations, there's one situation. We defibrillate patients that are in AFib. And then you go to Tracy, let's go to another electrical thing. Sometimes patients that are ventricular tachycardia may not have a pulse. And we treat them with pulseless EKG, just like it's defib. But basically, the patient that we defibrillate, the music bus is outside, the door's open, just got to take them out to the line. So we defibrillate a pulseless, breathless person. If the patient is in, say we're going to break it just a minute and come back, and hopefully not me, Erica bring that guy. So somebody, say the maintenance guy will come in to sweep up and he's laying here on the floor, and we come up and check on him, and we don't get a pulse and he's not breathing. What three rhythms, what keep it in? Asystole. Actually four. Asystole, which is like PEA, pulseless electrical activity, defib, or pulseless EKG. The only way to know that is to get it, put that monitor and set. And then if it's pulseless
showing a little support in there. We'll see. But that's the last semester you sent me this report. Yeah. And it's good you can't go around. I don't want to have to stay right there by that podium. And I don't know how well this will record, but we're going to see. Okay. Going to Michael's thing tonight? Yes, yes. I don't know if I need to stop it while we're not.
started back. Any questions or clarifications between fib and flutter? They're both atrial dysrhythmias. Like I said, healthy hearts don't fib or flutter either one. Flutter is more organized. You'll see what I'm saying when I say it's more organized and how it looks on the screen. It's a dysrhythmia, but it's more organized. Flutter, there's nothing organized. With fib, flutter organized, fib, there's nothing organized about it. You have a rapid atrial rate. You have an irregular ventricular rhythm. You have fast ventricular rate. You may see on the chart or on the EKG, it will say even irregularly irregular. That's what atrial fib is. It's irregularly irregular. It's just a mess. You need to treat the same medications, treat the same, because they are both atrial dysrhythmias and they are rapid dysrhythmias. With the fib being more rapid than the flutter. But the medications are the same. The cardio alert, when the heart rate is fast and the patient is symptomatic and you're unstable, or the cardio alert takes long to your damage medications and the patient gets no response. Let's move on to the ventricles. Because the ventricles contain those pacemaker cells, they have the ability to initiate impulses, like we talked about earlier, when they receive no stimulation or electrical stimulation from the SA or daily node. They will begin to pace the heart, but with the third minute out, so 20 to 40 beats per minute is the best they can do that. But because those pacemaker cells are there, you add some irritability or ischemia anywhere out there on the ventricles, if you go on the left or right ventricle, and there can become some excitability because of the irritability. So you may notice the patient may be clicking along in normal QRST, and all of a sudden you see this big line of large funny looking thing. It's like, what's that? We call those PVCs or PVDs, different terminology. PVC stands for premature ventricular contraction. So the ventricles on their own, with no instruction from anywhere else, initiate an impulse. Remember, the electricity is what gives us a mechanical response. And that gives us a normal response when we have proper levels of oxygen, when we have good coordinated blood flow, when we have normal levels of electrolytes. You impair any or all of those, and you can get some irritability. And irritability/excitability. Not all excitability is in the cardiac cells. So, say somebody's got some coronary artery disease and they have PVC. How do we know what a PVC is compared to everything else that is looking at? What characterizes a PVC? Is there a P wave associated with PVC? Why not? It's a premature ventricular contraction. The SA node and the atrial chambers are totally innocent. They have nothing to do with it. The ventricles did it on their own. We only have a P wave show us on the picture when there's atrial electricity or atrial repulsion. So a PVC does not have a P wave. And what did we say was the normal time frame or the width of a normal QRS complex? 0.04 up to 0.12 seconds. One itty box up to no more than 3 boxes when you go across its time. So PVCs, things that characterize or tell us that's what my extra P is. There's no P wave associated with it, and the duration is always greater than 0.12 seconds. It's like eating an El Cero all week. It's fat. It's a wide disorder with the QRS. No P wave. Duration, if we measure it out, it's greater than 12 seconds. like if our PVC is going upward, then the two-way is going downward. There's an inverse relationship between the actual PVC and the two-way. When we talked about last semester, we talked about PVCs, they may be unifocal or multifocal. If we had a patient who's having PVCs and we run off, say we run off 30 seconds worth of paper, we'll do 30 seconds worth of electrical activity. And in that 30 seconds, I have a total of 4 PVCs, and they are identical. If I were to put one on top of the other, they're identical. What name would we give those PVCs? They look the same, they're uniform, they're identical. That's unifocal PVCs. And PVCs are not good, but if you're going to have them, unifocal is better than multifocal. Unifocal means I've just got one little hot spot out there. It may be, from hypoxia, ischemia, maybe some stimulant drug the patient's taking, but unifocal PVCs tell us we've got one hot spot which we can be concerned about. For the multifocal, meaning we ran off 30 seconds worth of one tracing, and I've got at least 2 different looking PVCs. One's going up, one's going down. That means there's multiple areas. I've got more than one hot spot. So multifocal PVCs mean multiple problems. That patient is more likely to have a Jesus bus rhythm occur later on. Multifocal means multiple areas of irritability, ischemia, and more problems for us down the road. Do we get our panties in the wad and get ready to treat the patient at the first sign of the PVC? No. Healthy hearts, I said healthy hearts don't mean clutter. Healthy hearts can have PVCs. Somebody may come in, maybe they get doing, I'm hyper enough. I don't do the Red Bull or any of that stuff because I probably be like a honeybird on cocaine. But say somebody is taking stimulant medications. I've seen a young female who was perfectly healthy cardiovascular-wise, but was given prescription diet pills and was drinking lots of caffeine and stuff. She had PVCs, unifocal PVCs, not anything to be concerned about, but we stopped the medication and I didn't do it the right way. But healthy people can have PVCs. Some people are more sensitive to like pseudoephedrine or medications like that, herbal things. But we get concerned about PVCs when they follow a pattern. Like somebody, a patient is hooked up to the monitor and they have more than 6 a minute. More than 6 PVCs in a minute. I'm going to get a little antsy. And think, okay, what drugs do I need to get now? If their PVCs are multifocal, meaning I've got 2 different looking ones there on my screen or on my screen that I put my finger on now. They're multifocal. I'm going to be more concerned and think, okay, I'm going to spray that PVC. If I know for a fact, even in history, because when you're out working or in the ER on the floor, it's not like the clinicals are kind of thrown in there, you're there every day, but you would know your patient's history if they came in via paramedics or if they were on the floor and admitted, you would know the history. By that I'm getting at, if I know for a fact that this patient has had an episode of ventricular tachycardia or AFib in their past history, I'm going to be getting my nerves open and the crash fiber and getting my nerves out and supporting life and a little bit. So you consider treating PVCs in more than 6 minutes, when they're multifocal. I know for a fact this patient has had the ventricular dysfunction before, like we have when we did. When PVCs occur close to the T-way, if you were reading about that last semester, T-way, what's going on in that T-way in our picture? T-way means what's going on in that close heart rate. Resting, recovery, repolarizing. So it's a very vulnerable spot. So the PVC is happening more close to that, it could totally knock everything out. So PVCs are real close to my T-way on my monitor. I'm going to be really antsy. what are, what's a drug of choice for which we can use this? There are a couple of them talks about. ACLS talks about several. What are some of them? Lidocaine. What's another one? Another one more expensive. Another one. Okay. Lidocaine is good. It talks about, ACLS talks about propanamide. But drugs for ventricular dysrhythmias. Lidocaine is tried and true. It's old. It's cheap. There are patients who love it. But lidocaine is a drug of choice for ventricular dysrhythmias. When it comes to ACLS, which in an emergency situation, in Chicago County, there are beds and things that are built in, there's scales and beds. But a lot of these drugs, emergency drugs, are based on milligrams per kilogram. This is where you come to estimate. If a little bitty driving lady in the nursing home that doesn't weigh 90 pounds soft wet machine, I'm not going to give her, 100 milligrams of lidocaine or like it. She probably doesn't weigh that much. So it's based on milligrams per kilogram. If you can get a weight, good, but if not, we want to estimate. What do you remember saying? If somebody's having if they're having PVCs in these categories we talked about, and the medicated was say lidocaine, like the physicians told us to give, this person's conscious and alert, without administering lidocaine, something like that, you can go slowly, because you can have some walking problems. So lidocaine is based on weight, milligrams per kilogram, and you want to give it no faster than 25 milligrams per minute if you have conscious. 25 milligrams a minute. And we continue to monitor the patient. Anytime, as far as lidocaine or any of the triggers in this individual ACLS, what do you remember, like if you give somebody a really specific drug and it fixes the problem, they go to an IV, starts a trip. You got to follow it up with a drip to maintain the desired response. So, say our person was having 10 PVCs a minute, they've had a heart attack before, I know they've had an attack before, they're multifocal, all that little checklist, check. The doctor tells me with lidocaine, we do, hopefully you will see increase, the PVCs will stop, but we've got to paint a drip, continuous drip, or we'll be right back to square one. Any anti-dysrhythmic drug, any drug that you give IV push that fixes the problem, you're going to have to paint a drip. The drips we titrate to get off as soon as possible. Those doses will be some time, but if you don't follow the drip, especially with the ventricular lidocaine, with those, then you're going to be right back to square one. I had a student one night, she's working in our little unit, and she called me, and she said, my patient's on PVC, so I thought, well, festival. What are we talking about? And she said, well, three, I said, three right together. We got there for three, and then we got, she said, no, it's 3 o'clock, and I'm like, you're not waiting, no, don't wake him up unless you want, it's a junior in your lifetime. Yeah. But, okay. Remember, I think we talked about mnemonic devices. Anytime we're taking care of a patient with having PVCs, and then we're loyal, people are not ill, monitor, O2, IV, lidocaine. And in ACLS, we're trying to teach IV O2 monitor or O2 IV monitors, all 3 things we do ASAP at once. So monitor O2 IV lidocaine. monitors are wonderful, but they never ever treat them without going to check on the patient. As far as like I said, in PDCs, very common dysrhythmia after an MRI, when you keep coronary syndrome, like you see in ACLS. Ventricular dysrhythmia are very common. They start out with just a few PDCs, and if not assessed or acted on appropriately, then it could go on into Jesus plus 1 and Jesus plus 2, acting or reproduction. PDCs are ventricular dysrhythmia. And it may be something innocent like stress or drugs, but like ACLS or the patient under it's usually pulmonary damage or ischemia, and it works if you don't act on it. Ventricular tachycardia. Not to be confused or mixed up with SVT, supraventricular tachycardia. The supraventricular tachycardia, SVT, that's actually an atrial dysrhythmia. We've got an electrical problem in the top part, everything's happening fast. We've got P2Rs and T. The VTAC is just that, ventricular tachycardia. We've got rapid firing impulses, the ventricles are not taking over. The thing that gets confusing with rhythms, a patient who's in VTAC, the ventricles are the terrorists. They are the most aggressive dominant person gets their picture made. Now the SA node may still be firing, but the ventricles are taking over, and all you see, these are just PVCs. There's no P waves that are visible. Okay? That part may be working, but in ventricular tachycardia, it's a ventricular dysrhythmia, it's an abnormality, talking Jesus bus days. It's very common after the night. Stable with ACLS, we're going to talk about tachycardia, stable and unstable, and look at tachycardia, VTAC, and those things. Now, can a patient be stable with VTAC? Maybe. ACLS things have changed. As I told you about the pre-cordial pump I did a long time ago, that used to be the recommended thing. If you saw somebody on VTAC, we did that. But VTAC may not have a pulse, may or may not be, if they have a pulse, then it's going to turn quickly stable versus unstable. It will take a long time to make up your mind, and then you may totally you're unstable. And ACLS guidelines coming out, this is a biggie, and we need to treat it more aggressively. But VTAC may not have a pulse. If they get-go, they go into VTAC, which means right there, we don't feel a pulse. How do we feel it? Just like it's VTAC. So VTAC, no pulse, is VTAC. VTAC with a pulse, stable versus unstable. Drugs of choice. If we're going to give us drugs for VTAC, what would be drugs? Or a drug that we just talked about. PVC is a ventricular dysrhythmia. VTAC is a bunch of PVCs. And for definition, when somebody, if they have 3 PVCs together, plan, we call that constitutes VTAC. And usually they just have 3 beats, and then it goes away on a non-sustained VTAC. But this would be when every beat is a PVC, it's ventricular tachycardia. So our drugs of choice, again, if we're going to drugs, medication, anytime we talk about ventricular dysrhythmias, we need to have the heart open and be ready to put their hands on one. Lidocaine, what else do we talk about? It used to be a wonderful drug called Tilium. It was wonderful, it worked, it was cheap, but we didn't do it. But be prepared to have those medications on hand. Lidocaine and Madisonville Community College, drug older than you all are, and it works. Probably lidocaine is the most frequently. So you should see that If they are intact, like an ACLS says, pretty much, I mean, stable versus unstable is a very fine line. The majority of them will be unstable. So what would be our treatment choice if they're unstable? We don't have time to go to drugs. It's like, Mama, I see my mama. Mama's been in 30 years. White lights, hair. What are we going to do? If they're intact and a pulse, but they're unstable. They've got cardiovert. The cardiovert, when they've got a pulse, we don't like it. It's going to be not a good one. But again, synchronized electricity. Synchronized electricity. Does that make sense? Everybody understand that? Now, like if I had said VPAP, no pulse, then you go right CPR. Yes.
So they're unstable, but
With
they
a
have a
pulse,
pulse.
cardiovert. Yes. This is the ultimate. This is where the Jesus last term originally came. Now, will VPAP can go into VPF even if treated rapidly and appropriately? It can still go to VPF, or if it's not appropriately, it definitely the very first code I will learn as a new RN, 100 days, you do it. So wonder I was going to lie and say, but I am. But this patient, and again, it's when you're out of work and you're removed patients, this patient was in a lot, and he was always a DNR. But he had been discharged and home about a week and came back in. His physician was out of town, and different during his program in Liberty, and there was no DNR order. And I remember he was the patient, my first job as an RN, and I worked on the second floor of California Hospital. I was responsible for a 4-bed primary care unit, 8-bed OB, like in the delivery, nursery, included, and a 24-bed med-surg floor. That was my first job as an RN, and I was just able to realize, hey, this is on their job. The good Lord was with me. This was back in the day, and my preceptor, and I told you my big dad on a bad day. And this patient, there was Doug James, who is now the DON in California Hospital, and I see this not new. He was working in the nurse's aide, and he did it back in the day, nurse aide worked staff unit. And this patient, this man, started having TBC. He started out, randomly one here and there, and he started having more. I didn't know what happened then. We had a little run, we tagged him, like nickel hitter, put that down, and Doug kept telling me his audience was not accepted. Kept telling her he was on TBC, blood pressure dropping, had a tag. He didn't do that, and then finally, he goes into VPAP. It is probably 30 seconds, and then he goes into VPAP. And that was my very first coaching session. And I remember the orientation because I was so scared, and everything. I remember when they did the orientation, we had a crash car on the floor, back in the OR, and the local crash car. And I remember the nurses doing the orientation and said, if you don't remember anything else, you're going to have open crash car. The locks we used to have, they were reusable things that would recycle. You went up and down, and the pocket would get it off, and it's like the cracks in the parts like they are now. Remember, she said, do not twist it, it will lock like a hairpin. And I'm 20 years old, scared to death. They finally called Bo, because they get the nurse, he's a DNR, like goes like there's no order for DNR. Dr. Unitas out of town, we're like, oh, she's still on this coded. So somebody brought the crash cars. I'm about to code myself, I'm hyperventilating. And they pushed the crash car out, and she's been on it for 20 plus years. She grabs the lock, and they twist it. Do I have to dump him to say, that's not right, it won't open? No, I sit there like, when she twists it, it won't open. So we ended up taking that OB, but he probably, but still, I mean, it was tiny. The crash cart had been all the same, and even a 50-year-old in my, the way it was handled, it would have been the same. I don't think she'd acted any differently if it had been somebody that had never been there. You know, you'll find out real quick when you get out, and Loretta will tell you, when you'll see real quickly probably already seen people, I want to do it on me, or, oh my gosh, I know they're getting this school next door. Be fit. You got be fit, you got to be fit. I think I've used Loretta like jockeying for fibrillation, like if you were behind me when I weighed 230 and started at spandex with defibrillation. That's what big fit is. The ventricles are like a big bowl of vodka jello in here, just shaking it, or a bowl of noodles, just shaking it. That's fibrillation. So the patient in big fit is pulseless, for breathless, for dead. And if the bus is coming, the white light's there, and they are coming to dead, from the breathing and functional standpoint. The only chance of survival they have is early diagnosis of the condition, like get the monitoring and see what we're in, and defibrillate. You know, the quicker you get, you know, defibrillator there, the better. And even then, the prognosis is not too good when you feel it. And the goal is to deliver high enough amount of electricity to kind of override the irregular electricity that's there, the chaos that's there, and let normal take over. So I don't think I talked about springs. Cardioversion, synchronized electricity, lower the rules. Okay? It might be 50 to 100 joules for an average size adult cardioversion. So the fibrillation, we're talking 50 to 60. You set your fix on it, you set your electricity by joules, and then the velocity that you're centimeters and everything, so let's say. This cardioversion, lower electricity to synchronize. 50 to 100 joules, maybe a little bit more cost. The fibrillation is 360. It's what brings the patient this far off of the structure. But the fibrillation. As soon as you realize you've got defib, you've got defib. And this is, if you look at your algorithms in your CS book, I call them like recipes for emergency cardiac care. You've got defib or pulses impact. This is exactly what you do. I can remember, like when I first started, took my first ACLS class, you weren't allowed to talk to guys, you had to spit out, memorize this stuff. Now, in the classes, you got the pocketbook, I mean, you can't sit there for time, and you have references. And guess what? In the code situation, depending on where you work, codes are something you do every day. We just have code rules pretty often. You call, you don't use it, you lose it. But I can remember I was real impressed with the earbuds, and we had codes, we had a little pocket guide, and it's, guess what? As long as ABC is taking place, everybody reading circulation, you've got a minute to group and say, okay, this is what we're doing, this is what needs to be done. So it's okay, yes, it's moving on your feet, but as long as ABCs are managed, you've got some time to think, okay, what do you want to do? Had a physician who said, and I'm not the doctor I've seen, he delivered me, and we had lots of fights, and he told me one night, he said, you know, I delivered you, but the life of me, I remember when we went to medical school, we were having a disagreement that we kind of, he said, you're too pushy. Anyway, we had a total night, and he had his own algorithms. If we had an ACLS, like a book, pocket guide algorithm, we had it changed the crash card. I changed it to the crash card in the ER, so it would be there. So we had everything there, where we would code, and I'm like, where is that crash? He would call me with his own algorithms. There were notes written on mine. I just had it like, Dr. Smith told me that his own algorithms, but actually we did top down with it. Luckily, we didn't go away. It's okay, you know, ABC, everyone reading circulation. And then, you know, for nurses who work ER and primary care, who work post-day, cath lab, every cardiac cath I've ever been in on, except my brother, ended up kind of a little bit covered. They got families with this, and they got a lot of stuff. So it's routine for some people, but for most people it's not. So most nurses handle nurse do actually do, but for most of us it's not code that I witnessed when I was here as an instructor, people couldn't get the room. I'm like, they called a code, and I'm like, 20 people came and running, and I'm like, this is almost as bad as I-3 or 4 sometimes. And they'll say, you need to put you in the school, which is good to be a bigger coach, because you're going to always be better. We had a ER doctor one night, the ambulance was leaving for the rest, and he was a little startled. It was his first time out of the hospital. We were waiting at the ambulance for like a 5-minute ETA, patient was in, we did, and he was been down there constant, and we did, and we done the day in, and he said, I said, cookies here. What do you mean? I said, maybe respiratory therapist help with your minutes. He's got that's a coat tape. He's like, I don't want to work coats like that. But that's, ACLS is good to have, and in places like this, but too many places do. Say somebody's in DPS, they're running a code. How many people ideally would you need to run a code? 6. What roles? What's the role? Recorder, a very important role. You don't have to be pushing on the chest or pushing drugs. The recorder is a very important role. Because guess what? A lot of these drugs you repeat every 3 to 5 minutes to max out dosing. You think I can remember that. You can't remember your name. So if you're somebody to say, I'm a lidocaine, it's kind of a connection. So recorder, what else? That's one role. What? Airway. Someone breathe, manage the airway, okay? Depressions, okay. What? Somebody ran a defibrillator. And what else? Good for somebody to do the pressure part, get meds, and that sort of thing. And somebody needs to take charge. You can see on the video and the life medical stuff. Somebody, yes, it's a team effort, but somebody has to be in charge. It can't be Laverne and Shirley and just the mental and just coding somebody. Somebody has to step up and not be ugly about it, but you do this, you do that, you do that. Yeah. Okay, BFib. You got BFib, you got DFib. So, how many times can you defibrillate somebody? Is there a rule? Once you start, when the physician has to call, when you start the code, I've worked some codes that were 30 minutes, and the patient got a good challenge, or I've worked some that lasted a whole lot longer, still had the same outcome. But there's not a rule that says you have to defibrillate 15 times for the death. A lot of it depends on the situation, what you're doing, the history, and that sort of thing. But as long as you're ABCDE, somebody's recording, you're getting the appropriate drugs, following our direct supervision response. Now, I can't overemphasize good and effective CPR. We kind of, yes, ACLS is wonderful, important, but that BLS, good effective CPR. How effective is CPR to also? Would you say? It's pretty good, but and CPR is effective if we watch the crystal fall out the floor, we go to CPR when they're starting immediately. Her chances of survival are better. We call the ambulance office is right there. Chances are paramedics will be right over to ACLS. But in all reality, out in the real world, how long is it sometimes before basic skills are started? And then it may be 30 minutes sometimes before ACLS. And the longer somebody's down, the longer somebody's in this room, distributing so to speak, chances of survival are not good. And even if you bring it back, you don't have. Because they're pulseless, breathless, the person's dead, don't have the purposes. DFib, so we're doing CPR, everybody breathing circulation, defibrillate every 5 minutes or so if you got code. One thing, there are different drugs to give. Say, epinephrine is a synthetic catecholamine. It's not a rhythm-specific drug. You use it in a lot of cardiac emergencies. It kind of tries to pump the other things we're going to do. The first rhythm-specific drug you give is lidocaine. Does that make sense? Epinephrine is just, what is epinephrine in our bodies? We'll get scared. What does epinephrine do? It's kind of fight or flight. Well, this person's dead, so they're not secreting that catecholamine, so we give them epinephrine, and you give that. There's no max out dose. You give epinephrine repeatedly. The first rhythm-specific drug is lidocaine. we give the person lidocaine. We repeat that until we max out. Then we go to the next drug on that recipe for emergency cardiac care. You don't get one, and the next time you're, let's try this. You start with one, you max out on that, and you go to the next one. What? Lidocaine and better on okay, line. But whatever you, that's a precedent. Yeah, that's kind of like your epinephrine, but that's not like you said really specific, but that is right, you did it one time. But once you get there with a specific drug, you max out, and then you change to another. You don't sit around, you'll be sure what gives you a problem if you do it. And whatever does fix it, you start and back up there.
You're not supposed to mix APR
No, right. You start with lidocaine, you would give lidocaine, just like the code protocol said, until you maxed out, then you're done with lidocaine. If they haven't responded in the maximum doses, they're not going to, so you go to another one, max out on that. And if they don't respond, then you try another. You don't flip flop back until you don't get to the second one.
What's the max dose?
Lidocaine, usually 300 milligrams total, 3 milligrams per kilogram total. But if, you know, you start with one, you finish that dose. Get what question did you say? She asked about maximum dose. It's like 300 milligrams or 3 milligrams per kilogram on the pound. She give it usually 3 times, and if it has at least been 3 different doses, you get it one. And even, and like I said, this one, if I had $1 for the code I worked, I wouldn't have to be standing up and talking, other than I like to do it. But probably, and if your student experiences too, probably 50%, not even 50% recovery from this instance. And again, it's a situation. Probably the longest program I worked was a 20-something-year-old young man who was the same age as the doctor. Think about this small town in North Body. This is the boys in the car wreck. And one was a friend of the doctor's son, same age. And the kid, he had internal injuries and stuff. He was a big kid when they got there with him. With the parents, got through, and they started. We worked on him. And finally, this physician's brother was also a doctor at our hospital at that time. He took the code to get him out. He wasn't going to 30 minutes into it, he wasn't going to make it. But he just kept on. We used I used all the epinephrine in the hospital just about. Get from the time to where it's finally, my supervisor snapped it up and called us back and said, look, you won't let us do it. We came physically work this brother out of the program. I mean, we worked on almost 4 hours. And it was, he wasn't, they get massive internal trauma and stuff. We would call it. Sometimes, it is hard to call a brother, somebody 21 years old, and you got somebody who's saying, yeah, who had cardiac cripple, not that you don't think it's spiritual, but somebody who just walked away from her grandma and her own peace, somebody's 21 and you're wrong. But like they will just once you start, once you begin, nobody doesn't say you do it for 4 hours. But this one, again, it depends on how quickly we deal with the case for us. It's about 2 minutes and 1 call. Okay, let's take another break and then we'll finish up with the blocks. Okay, we'll get finished up. Asystole. Again, make sure this is what comes up on the monitor screen. So check the patient, make sure they haven't removed the leads. Make sure that's exactly what's going on. And there's a little rhyme that used to be with some of the ACLS algorithms for asystole. It says, check me in another lead. You always want to confirm ACLS to make sure that it is not equipment, it is your patient. So check me in another lead, then you'll have a cup of tea. TEA. T stands for transcutaneous pacing. E stands for epinephrine. And A stands for atropine. So check me to another lead, then you'll have a cup of tea. Transcutaneous pacing, epinephrine, atropine. And epinephrine, I don't want to confuse you. Epinephrine, like we said, with the Jesus bus particular stuff. Epinephrine is not a rhythm-specific drug. It is a synthetic catecholamine that we inject to give this body that fight-or-flight response. So the heart will be receptive maybe to the drugs we're going to give and the electricity we're going to deliver as indicated. So epinephrine, and you give epinephrine, there's no maximum dose of epinephrine. Your rhythm-specific drugs, there are maximum doses. Epinephrine, there's no limit. You can use everything to let it in the hospital if so need be. You're not. So epinephrine is a synthetic catecholamine. You give epinephrine in clear or pulsatile pack. You give epinephrine in a systole. You would give epinephrine in PPA, also selectivity. It is a synthetic catecholamine, nothing more. But you give it every 5 minutes. If you're coding somebody for 3 hours, every 5 minutes they can have a dose of epinephrine. Atropine is the epinephrine is the synthetic catecholamine, a rhythm-specific drug. Asystole is atropine. Atropine accelerates, and you definitely need to accelerate. Is there another name? But again, atropine is one of those things. Again, if you give it 3 doses, 5 minutes apart, no response, I'm not going to have a response. So you just keep on with your CPR, and you definitely have to on the patient to see if you can get something to come back. Atropine has a maximum dose, yes. But got 3 doses, 3 milligrams, a milligram at a time, 5 minutes apart for a total of 3 doses or 3 milligrams. You're going to pay something. And probably your asystole, this is about like BPM. This is Jesus bus squared, more or less. The person's dead, and depending on what caused the asystole, usually it's hard to get somebody back on that.
So you know on TV when they shop when they're how they shop back into normal size. Is that realistic?
No.
You can't shop it. I know that. I'm just saying period.
Depends, a lot of it depends, Erica, on what. Now, I have, if a patient's in coronary care, they have to be either in the first 24 to 48 hours after denied coronary syndrome, more likely to have dysrhythmias. The PVC, the tachycardia, and the higher level heart block. Now, if somebody's on the monitor, they've got a seasoned 16 nurse at the bedside taking care of this man. Maybe so, but your average, like ambulance dispatch to Walmart parking lot, not, yeah. But even good though, sometimes depending on the situation. But probably you do have a better outcome if they are hospitalized and they go into that, as opposed to kind of going back for you. And a lot of times, basic life support is starting to get you sadly. You know, so they call the ambulance and it's like they want to do whatever there's nothing on the course to do, but you know, mom's going to do it. But TV is very unrealistic. They shock everything. Like you can hear a monitor being in the background, heart monitor, and they'll go defibrillator, so to speak. And everybody's intubated and breathing on their own. Okay, look over the heart blocks real quickly, but first degree AV block, second degree 1, 2, and third degree. With the second degree type 2 and the third degree, the ones we're most concerned with for ACLS, because those are the dangerous ones. First degree AV block is not really a true block. We just call it that as it prepares. But what makes it not a true block? Because there's no block of communication between the top part and the bottom. Every P wave was followed by a QRS complex. It just took it a little bit longer to do the job. So first degree AV block is just a delay in production. Delay in production. It fits all the same parameters of the definition of normal sinus rhythm, with the exception of one thing. PR interval, normal PR interval is 0.12 to 0.20 seconds. First degree AV block is always going to be greater than 0.20 seconds. A lot of times it is 0.26, 0.28. But a delay in production. Every P has a QRS behind it, which is kind of straggling behind. Very seldom does this get worse, and get deadly, and get lethal, and go to higher levels. But that's not to say that you ignore this if you notice this on the monitor. If my patient had been in a normal sinus rhythm yesterday when I worked, and I come in today and I go in to run my strips the very first of the shift, and I see this, what two things do I need to want to check real quick? Lab and medications, and have they been getting the medications correctly? So it might be an electrolyte disturbance, or it could be them becoming toxic, or being over-medicated with drugs that are prescribed maybe for, that they put on something for that. So first degree block, look at the meds and the labs. With proper assessment and intervention, the book kind of leads to believe this would be a bad thing. And if you don't watch and assess, it could be that for the most part, you've got somebody who's got a brain that's taking care of them, which is not really monitored. Second degree type 1, two other names for it. Remember? Mobix 1, M-O-B-I-Q-Z, Mobix 1, and then my favorite, Weedbot. Some cardiologists probably sat around and break a lot. That was his last name, and that's the young name. Weedbot. Again, second degree, AV block, type 1. Again, not anything I'm going to get real stirred up about. Yes, I'm going to look for labs. Yes, I'm going to look for meds. But again, this usually doesn't jump into a complete heart block and get the Jesus test. Now, I said earlier when we have to give a real name. We have to give a name before we know what to do for it. We don't know what we've got before we know what to do for it. That's particularly is true. ACLS, the protocols, the algorithms are a good book for emergency care. If I don't know what recipe I want to look up, it's useless. So you've got to have an idea of what's going on. And I said for the blocks, there are little characteristic things that go along as far as the P wave and the PR interval. The second degree type 1, which is delayed introduction. Every P and a QRS behind it just stagger a little all the time. In this one, there is a distinct pattern. Two words that I use, I probably said 100 times in class. Progressive lengthening. Progressive lengthening of your PR interval till wham, or bam, as everyone would say. You have a P wave, it's not followed by QRS. And guess who has type 2 diabetes now? It's diagnosed 3 years ago to take its water. All it is. That butter and mayonnaise will eventually catch up with her. Although she said on national television today, that she never ate like she cooked on a daily basis. Yeah, right. But progressive lengthening of a PR interval till you have a P wave that is blocked. So this is a P block. But then you start up the pattern again. But your ventricular rate is usually so the patient is not symptomatic, meaning we're only losing, in this example here, we've got 2 P waves and are followed by QRS. The patient's still got that pulse 60s and 70s, so they're not symptomatic. Progressive lengthening of the PR interval until we lose a block. We have a 2 block, meaning a little long P wave by itself and no QRS behind it. Again, assess their labs, look at their meds, continue to monitor them. But usually, the patient is asymptomatic because they have a ventricular rate that is pretty close to normal. Okay? Now, here we get more into the big guys, the ones that concern us, the ones that make it to Jesus does better in the garage, on this way. Second degree AV block type 2. Also called Novice 2, secondary type 2 or Novice 2. With this one, we have morphines and QRSs. Quite a few more than QRSs. What does that say to us? I've got Q waves more than I do QRSs. QRSs mean what? The ventricles are contracting and pumping blood into systemic circulation into the lungs. So with secondary type 2, you have more block impulses, meaning P's. The SA node starts the impulse, it gets to the AV node, the door slams shut, and it quit. So more P's and QRSs, so the patient has a slow ventricular rate. Does that make sense? Ventricles only respond when they're told to. The ventricles are hard to show it's not a good thing. So more P's and QRSs. Second degree type 2 can and will progress to complete heart block. This one should put you on edge because it can get worse, and it will if you don't assess and treat and stay on your back. May even if you do. Second degree type 2 and third degree that we'll look at in a second, I believe, those two are very common actually in as well in people consider your ventricular things, your PDCs, the attack you give. Blocks are very common and can be 30 days after regular life. Now, what you will notice, there are definitely more P's than QRSs, which is not a good thing. But a PR thing that kind of helps us lock this into our brain and differentiate it from the other, the P waves that do get through, that do have a QRS standing right behind them, get in half. Normally, the P waves that got through good. They got through right. So normal PR interval. So every P wave that got through and has a QRS right behind it, get it normally. So that's how, whereas the second degree type 1, progressive lengthening, so you have one P by itself and then we pick up that pattern again. So we have only a couple of P's without QRSs in second degree type 1. Second degree type 2, we're getting worse. A lot more P's than the QRSs, but that got through, it's normally they just end up going to make a big difference. Versus heart rate is going to be rate of heart rate. Drug of choice for symptomatic bradycardia is atropine. Okay. Is oxygen a drug? Yes. It is actually the first drug in any emergency cardiac care. Oxygen is a drug, and you get it on ASAP. If there's cardiac emergency situation, get O2 on it. Like I said, as earlier, O2 IV monitor is going to be simultaneously on this. Okay. Third degree or complete heart block. If not the Jesus does, definitely the Jesus passes for this one. And the bus will be coming to not take it. Used to be called in the older days, before, maybe not Loretta, but Loretta and I are kin actually, kind of our family, so don't take that out becoming friends and not certain. In the olden days, it was called complete AV disassociation. Atrial ventricular disassociation. And I don't really have a problem with that name, so tell you what the problem is. In third degree or complete heart block, you have no dollar store deal, 20 to 40 beats per minute. That's not enough to maintain one load of brain kidneys, and we got that. I think I said it's like we're divorced, they can't afford a new house, so we're living in the same house, but they ain't talking, nothing conjugal going on. We're just there, no communication whatsoever. You have a lot more keys than QRSs. And it may coincidentally look like it, but do you remember what we said about PR and P waves for the curvature of the heart valve? There is absolutely, positively no correlation or relationship between P waves and QRSs. They say no is doing its thing, it's being picked up on paper, difficult to doing their thing, it's being picked up on paper. Sometimes, just by luck of the draw, it may look like this P wave goes to this QRS. No, that's just how it may. There's absolutely, positively, no correlation or relationship between P's and QRSs. The best heart rate this person is going to have is what the ventricles are making. That's 20 to 40 beats per minute. The white lights in the room, you want to see them off. Drug of choice or symptomatic bradycardia is exactly what we're doing here. Atropine. If we maxed out, say we gave milligram of atropine, we assessed, we monitored, 5 minutes later we repeated that dose. 5 minutes later we gave the third dose of atropine, no response. Guess what? Probably going to be response. What's our next thing to do to maintain this patient so we can get some test x-rays, find out pacemaker, transcutaneous external pacing. Sometimes, like I said, this is a common, the high degree block, second degree, 2, or third degree are very common after the line, as all of them particularly like boys. A lot of times you've got a pretty large, with the mild part of the heart straight, you've got dead tissue. Dead tissue doesn't work too well. So it may be that after, as we start to heal, there may be conductive system and impulses can pick up. So it may be a temporary thing for pacing, but definitely the external pacing, and it may end up being a permanent implantable dual chamber to pace the heart. A lot of times if it's from an MI, and the process starts to start to heal, that never we can't receive that cardiac tissue, but we can heal and get the lateral things and maybe get back to it. So you can have external pacer on for several weeks. So first degree AV block, this is related to that MVP, that QRS. Second degree type 1, weak stop. Not a big deal really. Progressive lengthening PR, you have one key by itself, but there aren't enough little lower keys to make a difference in our overall heart rate. Again, this first degree AV block, second degree type 1, look at the mirrors, look at the light. Second degree type 2, third degree, bad news. Especially if somebody's having people syndrome, you know, if you know they have it in mind, understand, be on the alert, monitor for those, be ready to give the meds, give the drugs. Now Thursday, I mean, this is kind of a basic review and hopefully help you all knew all the answers we did in your smart group that last time. But with ACLS, we'll take things a little bit deeper, but the drugs, we talked about some doses today, but just remember ACLS, you know, you got to do the name. And there's no, if you could look at your algorithms like bradycardia, like if it's this, you go down the left side. If it's this, you go down the right. It's pretty self-explanatory. And the drugs. And like we mentioned today, the most important thing to remember is your head code, that kind of thing. Your really specific drugs, and know your maximum doses. Start with one, stay with that, and you reach the maximum dose, then go on to the next one. And whatever fixes it, take a risk. I always like to say next to that expert consult, that's what I would do. And you may, that is the perfect thing. all the I study on Lake Road. Okay, and I. But we all know this stuff. And is there a pre-test? This is a pre-test for. Have y'all done your pre-test yet?
Yes.
Have you do?
We're 28.
What?
We're 28.
Out of
60 maybe.
100. Well, if you were to take it today, you'd be better.
Maybe so. We're taking it to that.
Yeah, okay.
Everybody knows they're coming back on the next semester one, to be here Thursday. If not, we'll see you Friday. Be here at 9 on Friday. We're gonna take you 6 at a time.
This year, this year, this is the first day semester. Oh, good. I couldn't stand off leaving in my room.
Amen.
When I see a list of there's like that. Oh, no. There's 12 on.
Get them information over.
Do what?
Get them information over.
Okay.
Just go around and sign.
Stop recording here.